Dear board, dear colleagues, I'm very thankful for the organizers of the conference for the opportunity to participate in the conference, and I think for me it's a great honor to uh, to present a historical overview uh, about the development of the methods of vessel grafting that is called now stent grafting. When we started doing this, we called this distant and prosthetic surgery. You know the core of the methods. Our goal is uh, to use synthetic grafting, stent grafting. The idea, only just recent years, think for some scientists from different countries throughout the world, and one of our scientists, local scientist, thinks it's became known to a wide circle of specialists about the priorities of our country in the development of this method. It's become known that first time in the world here in the USSR, and grafting of thoracic aorta, of aortic arch, of abdominal and iliac arteries. It was for the first time, the main types of and grafting was made, and hybrid operations on the aortic arch. It's known that the idea of the distant and prosthetic, it was Charles' daughter who was the first announced this idea. In 1969, he published his work, experimental work. He shared his experience of placement of synthetic tubes and metallic springs in from carotid arteries in dogs into their knee arteries. To implement the idea of daughter, the key problem was a creation of a self-fixing synthetic graft that would be flexible and can change the diameter, that helped to move it from superficial vessels into the deep large diameter vessels. Starting since 1983, we developed the constructions that would give the stent self-fixating qualities. We performed different types of constructions, different versions of springs, and we performed a radial cylindrical spring. Time required this construction. In 5 months after our patent, Gentuka patent was registered from in the USA. It was international registration, and now in the world it's a Gentuka stent, although our patent was 5 months earlier. It was a completely new geometrical construction. It required to be studied, the property of this construction, to identify a radial strength of this spring. It was important for its functioning. For this purpose, we developed and created a number of devices to study radial forces of stents, and we was very cautious before starting inserting this kind of construction into the body of a patient. Each springs, we know what kind of diameter and what strength may be applied to the wall of the graft or vessel. We cooperated with technical research institutes, scientific institutes, and even we have a monography of these kind of experimental studies. Uh, after creation, after invention and studying of this construction, we have first experimental stent graft, synthetic stent graft that can be inserted through the femoral artery and then fixated into the aorta without intervention in this segment. But it was necessary to study the behavior of this stent in the pulsing flow of blood. We took the cadavic aorta, and with the artificial circulation device we imitate pulsing flow with the preserved blood, and we identify the optimal strength of spring that allowed the uh, application, fixation of this graft. Also, we developed a delivery system. It's our first delivery system that that evolved. It was a transport part, joining part, and packing part with the hammer valves. Its first experimental delivery system so that we used in experiments on animals. It's a clinical delivery system, real system of endoprosthetic that was used for the first operations in the clinic. For setting of this prosthesis, of this graft, we need balloon graft. We didn't have this type of catheter at that time, and we needed a precise diameter of this catheter. It has 3 layers: outer latex fabric layer, inner latex layer are of a certain diameter that guaranteed a stable diameter of this balloon. This balloon in natural size, after also we applied at that time there was no perfect CT or ultrasound examinations. We used these catheters to measure the diameter of the aorta. It's the animal experiments or for how graft behavior of the graft. We started experiments on large dogs weighing more than 30 kilos. It's from operating room, experimental operating room photo. In 6 months, they are very good functioning of endoprosthetic devices. And it was proved that no significant changes happened in this segment. Successful experimental studies allowed us to apply these methods in clinic And for the first time in 1985, we started from the iliac artery as most simple and less risk methods. It's the first operation in the stenosis of the iliac artery. It was a combination of bypassing femoral artery, posterior femoral artery. 29 operations were performed on this part. We had a case, a patient from Belgrade with a traumatic aneurysm of the aorta. In Belgrade, thoracotomia was performed, and it was suspected that it was a tumor of the pericardium. And we started the prosthetic procedure so that to prevent repeated thoracotomia. It was in 1987. It was the first grafting of the descending aorta. It's a schematic procedure from a left femoral artery approach. It's CT. In 16 years, the patient survived for 18 years, and then he died of a cardiac ischemia infarction. In 1989, we tried to end the prosthetic with the use of bifurcated prosthesis, abdominal aortic aneurysm. Unfortunately, we had a complication, the twisting of the branch of the endoprosthesis. We understood that we were not ready for grafting of this part. In 1991, this patient from the hybrid procedure for aortic arch aneurysm, the aneurysm of the distal part of the aortic arch with the involvement of subclavian artery and left carotid artery. She was performed for the first time hybrid operation. It's a schematic of this operation. The operation was performed from two accesses, from left femoral artery and from ascending aorta. Sternotomy was performed in the brachiocephalar trunk. The left carotid artery was transformed and outer venous graft was performed. Debranching was performed. With the help of ascending aorta, we suture synthetic prosthesis in the side. It was the system, the delivery system that was developed for this operation precisely to do and prosthesis grafting from two axes. It consists of two parts. And the proximal part, it was a conic part with a long catheter. That was inserted into the ascending aorta graft, and the distal part was in the left femoral artery, and controlling the movement of the system and influencing both ends of this graft. We move into the aortic arch, and we manage to place this graft precisely from both, manipulating on both ends. It's 3 weeks ago CT. The female patient is still alive and in good condition. In 1993, the patient with profuse lung bleeding, aorta bronchial fistula with access from double access from this system, and prosthetics was performed in this emergency case. Its schematic scheme of the operation: one access from femoral artery, the other from a CT. There's a number of patients. We performed and a prosthetic from two axes. This we have abdominal aorta. It's the first successful and prosthetic operation with the one piece bifurcated and a prosthesis. One of the first successful successes in the world with a one piece bifurcated and prosthetics. We developed the methods of hybrid or combined endovascular grafting via left common iliac artery from pararectal approach. With a specially designed endosprosthetics, we managed to perform endarterectomy in case of Lerisier syndrome. This access allowed to manipulate on the right iliac artery as well, and it simplified and decreased the trauma during the operation. At that time, we performed 94 operations. By the opinion of Criado, it was one of the largest experience in the world at that time.
It's okay, because I'm asked often times, how did we conceive this idea? How did we dare? And of course, while analyzing, reflecting on the past, while trying to answer this question, I would like to bring up the issue of mentorship. What were the factors? Well, of course, we got blessed. But as for the earthly reasons, I believe that the major prerequisites were as follows. We were the generation that basically were the founders of cardiac and vascular surgery in our country, and our generation had to endure a lot. We didn't have CT scanning, we didn't have ultrasound, we just used angiography, we did everything ourselves, we got irradiated, we were, like jacks of all trades. We fell in love with these invasive methods of diagnostics. Plus, we have love for experimental surgery. No one, in fact, performed open heart surgery without prior experimental work. Another peculiar feature of our generation. We were very poor. We had to work in the very poor environment. No instruments, no imported machines, but we were very enthusiastic, and especially such enthusiast as my mentor. Please show us the slide. Academician Salimov. I believe that many people, at least here, know this name. We couldn't wait till after all these machines and supplies are made available to us. That's why we again just used our enthusiasm, and it's a center for military industrial complex of Ukraine, and that's academician Shalimov, person in question, and the power and the capacity of this military industrial complex was used for creating these local machines and local supplies. It took about 10 years, but at least the machines were made available to us in Kharkov. And that's link to technicians, to engineers, was introduced by our mentor. So I believe it was very important. But the major stimulus for clinical science, without a doubt, were failures. Failures. And the lost lives of our patients, the patients with, like, again, dissecting aneurysm or ruptured aneurysm of the aorta, who were hopeful, and they were dying because of our failed attempt to rescue them. And so we were asking ourselves what to do, how to help this patient population, and that's how we perceive the idea. Correct me, please, if I'm wrong. In 2012 in Charing Cross, Dr. Trasivanchev presented your materials, and as far as I know, the audience were applauding you. Let's stand up. Let's stand up and greet Nikolai. We are not worse than Charing Cross. I suppose that we have a person with us who became immortal. I would like to thank Alexei Svetlikov. It was actually his initiative to invite Dr. Volodas to our conference. I actually had to make it clear at the very beginning what has been done was done in the former Soviet Union and the big country, because from anatomy point of view, yeah, the wire was manufactured by the Bauman Institute in Moscow. We used the prosthesis from again the polymer establishment in Leningrad, and the balloon catheters were manufactured in Dnepropetrovsk, elsewhere. And Belgorod was involved, using the materials produced in Moscow again. So we broke through because of like power, because of capacity of the Soviet Union, because of the morale, not commercial relationship. And we were able to approach our colleagues everywhere within the former Soviet Union, and we never got refused. It's not about Ukrainian experience, that the first experience of the Soviet Union. Thank you, Nikolai. Colleagues, do you have questions? Please ask questions. Okay, if you don't mind, I would like to ask a question. Dr. Karev, tell me, please. You are the person who made this first step, and it's acknowledged worldwide. I have a question in this connotation. I'm asking you as a doctor, from your point of view, and the grafting and the prosthesis as in current shape, is it satisfactory, or there is room for improvement? Oh, I had to touch upon this issue. Well, if we are to evaluate our current position, I just don't want to take too much of your time. Yeah, well, we call this method endovascular revolution. This approach changed the algorithm of treating the aorta and the vessels, large vessel. Plus, it made possible to treat the patient who weren't curable, who were doomed to death, and it actually became impetus for new approach. We started learning more about the aorta conditions. It actually prompted the development of the new diagnostic method, new equipment. You've seen like the hybrid suite, ORs, not speaking of CT scanners, etc. As for again the way ahead of us, I believe that vascular surgery is very far from being perfect. It's not. It has not even achieved the plateau. It's still going up, and it will. It's being challenged by time. It's going up again. And if we ask this question, what I'm concerned about, oh, certainly I have some concerns. Well, there is like a skew to engineering contribution, the technical details, and that's what I'm concerned. Well, that's like a threat. We are not plumbers, not blacksmith. We definitely have to draw upon like cardiac and vascular surgery, not engineering or anything else. Thank you. Let me say a few words. I can open the secret. Basically, till like the very last moment, we didn't know whether Nikolai would make himself available due to the situation. He's in, and we worried a lot. We're so glad he made it, and I would like each of you to disseminate name, propagate the name of this outstanding surgeon. Please tell your students that he's still in existence. You met with him. You